Today we are going to talk about ischemic heart diseases. It is a very important to discuss because ischemic heart diseases had become a major non-communicable disease in the world. It has many precipitating factors which we will be discuss later. So, what is ischemia? Ischemia is lack of blood supply to the tissues. When it is affecting the heart muscles, it is a ischemic heart disease. Clinical manifestations of myocardial ischemia can be divided into several categories. They are stable angina, unstable angina, myocardial infarction, sudden cardiac death. First, what is stable angina? Manifests as pain, discomfort, or tightness in the chest, arm or jaw. Is classically precipitated by exertion or emotional stress, is relieved by rest and/or nitroglycerin, lasts for a few minutes. Relatively fixed obstructive atherosclerotic lesions within the coronary arteries. Then what is acute coronary syndrome? It is a collection of three. Unstable angina, acute ST elevation myocardial infarction, acute non-ST elevation myocardial infarction. They are mainly due to rupture or erosion of an atherosclerotic plaque. Then what is Prinzmetal's angina? It is a spasm of coronary vasculature. Important physical signs in a patient with stable angina: tobacco tar stains on the fingers, xanthomata and/or xanthelasma, elevated blood pressure, diabetic retinopathy, glycosuria. Important physical signs patients with stable angina. Evidence of other vascular disease: carotid brood, absent peripheral pulse. Associated conditions that can exacerbate angina: aortic stenosis, heart failure, anemia, thyrotoxicosis. Canadian Cardiovascular Society. Grading of the severity of angina. Class I: ordinary physical activity does not cause angina. Angina is precipitated only by strenuous, rapid, or prolonged exercise. Class II: angina causes slight limitation of ordinary activity. Angina is induced by climbing stairs rapidly, walking uphill, walking or stair climbing after meals or in cold or windy conditions, or emotional stress. Class III: symptoms cause marked limitation of ordinary activity. Angina is induced by walking less than 2 blocks on the level or by climbing 1 flight of stairs under normal conditions. Class IV: inability to carry out any physical activity without discomfort. Anginal symptoms may be present at rest. Then we will talk about few investigations are useful in diagnose heart diseases. Electrocardiogram. Resting ECG is of limited value in patients with stable angina and is normal in at least 50% of cases. ECG may reveal ischemic changes, T inversions, ST depressions. Evidence of previous MI. LV hypertrophy. Conduction defects. Arrhythmia. About 1/2 of patients with a normal resting ECG exhibit abnormalities during an episode of angina. Second one is chest radiography. Establish non-cardiac causes of chest pain, reveal complications such as pulmonary edema, LV hypertrophy. Other important ones: hemoglobin, thyroid function tests, fasting lipoprotein profile, fasting glucose, stress testing, exercise ECG, ECG using pharmacological agents. Dipyridamole causes coronary vasodilatation by inhibiting uptake of adenosine, an effect that is blunted in diseased arteries. Adenosine works directly in a similar manner: dobutamine, a positive inotrope and chronotrope that increases myocardial oxygen demands. Then coronary angiography. Indicated in patients with severe angina. Evidence of ischemia at a low workload. Has a vital role in risk stratification. Planning of revascularization. The presence of severe stenosis, equals 70% luminal narrowing, in the context of chest pain with no other obvious explanation, is highly significant. Many patients with non-cardiac chest pain have abnormal coronary arteries and, conversely, Many individuals with coronary atherosclerosis have no cardiovascular symptoms. Then we will talk about management. They are given for treatment of stable angina. Has two main aims: to improve symptoms, to improve prognosis. General measures: increased physical activity improves fitness and exercise tolerance. Weight loss reduces myocardial oxygen demand. Stopping smoking may improve symptoms. Patient education about symptoms may reduce the need for revascularization and drugs. Anemia and thyrotoxicosis should be identified and treated. Optimizing therapy for heart failure may improve concomitant angina. Pharmacological treatment: patients with angina should be provided with a short-acting nitrate. Unless there are contraindications, SS blockers should be used as first-line anti-anginal agents. Patients who are intolerant of SS blockers, or in whom adequate doses are insufficient to control symptoms, should be prescribed a calcium channel antagonist. Aspirin reduces adverse vascular events in patients with angina by 1/3 and should be administered to all those without contraindications. SS blockers confer some prognostic benefit and should be prescribed whenever possible. Angiotensin-converting enzyme inhibitors may also reduce the risk of major adverse events, particularly in patients with diabetes. Cessation of cigarette smoking improves outcome. Concomitant conditions such as diabetes mellitus and hypertension should be managed appropriately. Management of hyperlipidemia, LDL cholesterol, should be 100. Then risk stratification. The prognosis of patients with IHD is related to 5 factors: age and general health, LV systolic function, extent of coronary disease, site of any severe coronary artery stenoses, stability of atherosclerotic plaques, coronary revascularization, percutaneous coronary interventions, PCIs, such as percutaneous coronary angioplasty and coronary stenting are effective treatments for angina in suitable patients. Coronary artery bypass grafting, CABG, is the most effective treatment for angina. 80% of patients are free from symptoms 5 years later. Disadvantages of CABG: early mortality is greater than in PCI, up to 5% in multivessel disease with impaired LV function, greater risk of perioperative MI, about 4%. Patients suffer the morbidity associated with a major operation. CABG is therefore generally restricted to individuals who are likely to gain prognostic benefit, or whose symptoms are uncontrolled by medical therapy and who are unsuitable for PCI. Okay, then we will meet with another medical lesson. Thank you. Hello my friend.